Okay, so first we'll start with the anisometropia. What is meant by anisometropia? So let's first break down the sentence. What is meant by anisometropia? So A meaning that there is no, aniso meaning it is unequal, and metro meaning that it is a measurement, and opia meaning that vision. So it is meaning that there will be unequal due to both eyes. So it will be unequal refraction in both eyes. So does it have an equal or a specific between both eyes between about 2 to 4 diopters? Usually it is named anisometropia. So less than 12 diopters, usually it is more tolerable by the eyes. So usually they are not significant, doesn't cause any significant problems. So again, anisometropia meaning that the both eyes have unequal refraction. So they can be both myopes or hypermetropes, or one will be myope and the other hypermetrope, or even one eye will be immetrope and the other is ametropic. But in any case of them, there will be a difference in refraction between both eyes. So why could anisometropia occur? This can be congenital, like you find a child or a newborn who is born with an equal refraction in his both eyes. So you may find one eye is myope or the other is hypermetrope, or even with both having the same type of refractive error but of large difference. Or they can born normal, but they develop the anisometropia later on. So we all know that the eyes are, or that when the newborn is born, it will be manifesting with hypermetropia usually due to short axial length of the eye, and they later on will develop myopic shift. So as long as the eye enlarges in size, this will lead to shifting from hypermetropia to myopia. And this is usually occur by the same means and by the same progression rate in both eyes. However, in some conditions, there will be more progression of myopia in one eye than the other, and this results in the anisometropia. Also, they can be due to regression of hyperopia in one eye. So one eye will be immetrope or myope, and the other eye will be hypermetrope, and there will be increasing in the hypermetropia of the other eye. Another reason for anisometropia that we discussed in the last lecture will be the surgical aphakia. So if we surgical aphakia and traumatic aphakia, in either condition of them, there will be large refractive error. So the eye will be highly hypermetropic. So it will be about +10 or +12 hypermetropia. So there will be large difference between both eyes if the other eye is normal or if the other eye is phakic. So again, surgical aphakia and traumatic aphakia can cause anisometropia due to large difference between both eyes. So how can this anisometropia affect the vision? The answer of this question will vary according to the degree of anisometropia. So is it a small degree or a large degree? And the difference, this difference can lead to either binocular vision. So the patient or the individual uses his both eyes for vision, and this usually occur for small errors. Or alternating vision. So alternating vision meaning that the refractive error is usually large, but the person has a good visual acuity, so he can use any one of these eyes for vision. For example, if the patient has myopia in one eye and hypermetropia in the other eye, leading to anisometropia, the person will use his myopic eye for near vision and his hypermetropic eye for far vision, and frequently alternate between them. So they have, it means both eyes having good vision. But if there is a large error in one eye and there will be a normal or near normal vision in the other eye, this will lead to neglecting this eye, which will what we know as amblyopia. So this results in uniocular vision. So the eye which has more ametropia and more refractive error will having a poor vision. let's put this into figures. How can we, or when do we have binocular vision in case of small errors? It was found that about 0.25 diopters difference in refraction between both eyes, this will lead to what's called anisocoria. Anisocoria meaning that it will lead to a difference in the retinal image size. So this difference is specifically about 0.5%. So again, 0.25 diopters difference in refraction between both eyes, leading to about 0.5% of difference in the retinal image size. So how much we tolerate? We can tolerate up to 5%. So if every 0.5% will be caused by a quarter of diopter, then 5% will be caused by quarter multiplied by 10. So the maximum that we can tolerate is about 2.5 diopters between both eyes. So what happens if we have difference more than 2.5 diopters in between both eyes? This will lead to big difference in the retinal image size perceived by both eyes, and this will not be tolerable, leading to that the patient will suffer from accommodative athenopia. So he will not be comfortable with glasses. The alternating vision for large error, this occurs in case of the both eyes have good vision. So the person usually uses one eye at a time, and especially if both eyes have good vision, the emmetropic or hyperopic eye used for far, and the myopic will be used for near, and they frequently alternate between both of them. So this happens if we have large error but both eyes are having good vision, and this usually occur if both eyes having large error but the difference between both of them is within the acceptable range. But if both eyes have large error, or one eye has large error and the other eye is normal or near normal, this will lead to neglecting, the brain will neglect the eye that has poor vision, leading to only uniocular vision by the sound eye. So only one eye is used and the other eye will be discarded, leading to anisometropic amblyopia, which will leading to squint. Just important notes about anisometropia, that the patients usually tolerate myopia more than hypermetropia, especially if they are a child. You can notice that in the child, when the child is born, usually the child doesn't look to a distant target, or the child is not interested in distant targets. So they don't catch a bus and they don't look at the sky or watching birds. They usually are interested in the toys and food and everything that is close to their environment. And they are more interested in the 1 or 2 meters around them. And this will lead to that the child will tolerate myopia more than hypermetropia. So if the child has myopia, it will be fine for him. But if he has hypermetropia, then he's got a problem. So that's why the hypermetropia will warrant a specific measurement and specific interference more than the myopia. So the disparity more than 1 diopter in hypermetropic patient is close enough to cause amblyopia in the more hypermetropic eye. So we can or the child can accommodate or can tolerate difference about 2 diopters if they are in the myopic side. But if they are only 1 diopter in hypermetropic eyes, this will cause the patient a problem, and this eye has a serious problem or has a serious risk of being neglected by the brain, as this is usually non-seeing eye. So you may wonder, okay, if the child has a -2 eye, and this eye is myope and can see well, and the other eye is a +2, so there will be difference more than about 4 diopters. So this child has anisometropia. So, and the eye which is the +2 are more prone to develop amblyopia, because the child cannot compensate or cannot tolerate the hypermetropia. So why does the child or why doesn't the child use his accommodation? So why we don't use the accommodation for this +2 diopters eye so that we can see clearly? This is because the accommodation is a binocular reflex. So in order to stimulate the accommodation, we cannot change or we cannot use the accommodation by different amounts in both eyes. So if we are going to use the accommodation, it will be symmetrical in both eyes. And for this particular case, if the child has +2 and -2, and the child, if the child is the accommodation will not be stimulated because the child can see clearly by the -2 eye. So the accommodation will not be stimulated by the hypermetropic eye because the other eye can see clearly. So I hope that this concept is clear, that the accommodation is a binocular process, so an individual cannot accommodate by different amounts in both eyes so that the anisometropia couldn't be corrected by accommodation. So let's come to the treatment. How can we treat the anisometropia? It will be dependent on whether the difference or the difference between both eyes is small or large, and also the age has an important factor. So the younger the age of the child and the smaller the refractive the error or the smaller the difference between both eyes, the more the ability of the child to tolerate the full correction. So child are having what is called the visual plasticity, meaning that their visual system and their visual system maturation are very flexible. So they can tolerate, they can upgrade, and they can compensate for refractive error more easily than the adults. So if a child has a refractive error, they usually tend to do well with full correction. They will be happy with full correction. They will not be annoyed from it. So don't hesitate to give the child the full correction if there is a small difference between both eyes less than 4 diopters, or if the child is less than 12 years. But we should stress on that the glasses should be worn constantly. And this will lead to that the symptoms of eye strain or athenopia will disappear within few weeks. But what happens if there is a large difference? If there is a large difference more than 4 diopters. Let's remind you of the Napp's rule that we mentioned in the last lecture, that if an axially ametropic eye is corrected by a lens placed in the focal point and the anterior focal point of the eye, the magnification of the retinal image size is the same as ametropic image size. So, for example, if we have a myopia and hypermetropia or hypermetropia that is corrected by glasses that is placed in the anterior focal point, which is 15.7 millimeter in front of the eye, then we will not have a problem because the retinal image size will be the same like ametropic image size. So the patient will not develop different retinal image size, and then we will be very comfortable with this. But actually and practically speaking, this doesn't occur because we don't place the glasses at the anterior focal point. So we don't put the glasses or the correcting lens at the F1 or the anterior focal point at 15.7 millimeter, but it is placed on the spectacle plane at 13 millimeters. We discussed this in the last lecture, and they said that this will result in difference in magnification. It will be difference in magnification from the if we place the lens at the anterior focal point. So the patient will have an anisocoria or different retinal image size. So what happens if we have a large difference, more than 4 diopters? We don't give full correction, because if we give full correction, there will result in anisocoria or different retinal image size, and this will not be tolerated by the patient, and the patient will complain from headache, from eye strain, from athenopia, and this will lead to will result in that he will discard the glasses. So if there is large difference more than 4 diopters, we do not give full correction. So what happens, or what are the treatment options then? One, we will give full correction. Second, we will give anisocoria. Third, we will give We can use glasses in different manner, or we can use contact lenses or focal lenses, or we can opt for surgical options. So how can we use for the glasses? As we said before, the one diopter or the one diopter difference between both eyes, the refraction will result in magnification of 1.3 x. So the more the diopteric difference between both eyes, the more the magnification difference, and this will lead to the brain will not be able to fuse the small retinal image that come from one eye from the large retinal image that come from the other eye. So how can we use glasses then? As we said, we cannot use full correction, but we can opt for other options. So we can go for full correction of the less ametropic eye and under correction of the more ametropic eye. And this will lead to decreasing the difference between both eyes. Let's see an example. If we have, for example, an eye that has -2 and the other eye has -7. So the difference between both eyes is about -5, which is beyond the capability of the eyes to fuse the retinal image size coming from both eyes. So what can we do? We can go for full correction of the less ametropic eye, which is this one, and less under correction of the more ametropic eye, which is this one. By this means, we can now make the difference between both eyes about 3 diopters, leading to anisometropia within the tolerable range, so that the eye will not be complaining. The other issue or the other thing is by changing the base curve of the two lenses, and this is usually the job of the optician. So they use a plus lens over a base curve of -12 diopters that will magnify the image by 1.6% compared to the flat lens. So by changing the optical properties of the lenses used in glasses, this can also be a solution to correct the anisometropia and resultant anisocoria. The more acceptable option, especially if for large errors, for example, if a patient has -10 and plano or no refractive error in the other eye, will be the contact lenses. Because the contact lenses, as we mentioned in the aphakia lecture, it will cause less magnification. So as it causes less magnification, this will result in less difference in the retinal image size between both eyes, so it will be more tolerated. We can go for contact lens in both eyes, especially if both eyes have refractive errors, or we can use a contact lens to the more ametropic eye and the glasses for both. So for example, if the patient has -10 and -1, we can go for about -9 for as a contact lens in one eye and the -1 diopter of both eyes. Or this example can be used more for patients who have presbyopia. So if the patient has -10 in the plano, they can having contact lens of -10 in the myopic eye, and if for the presbyopia, they can have their presbyopic correction of +2 or +3 or +1 or whatever for both eyes. So they can use the contact lens for far vision and the presbyopic correction for near vision. Another method of correction of the difference in the retinal image size that is no longer used, which is called the isoconic lens or a focal lens. We also have mentioned about it in the last lecture. This is as simply as a parallel plate of glasses that is placed in front of the eyes, and this parallel plate of glass will cause angular magnification but with no refractive power. So if the eye is looking to an object and we place a parallel plate of glass, this will lead to just displacement of the image. And this displacement of the image will increase the angle subtended at the eye, leading to increasing the magnification, or what's called angular magnification. But unfortunately, it is only about 5%. And given that this a parallel plate of glass or a focal lens are expensive and thick and heavy, they are no longer used. Some surgical modalities for correction of the anisometropia like LASIK, so we can correct the refractive error by subjecting the patient to a laser refractive surgery, or we can go for a posterior chamber intraocular lens implantation for aphakia to correct the high hypermetropia, or if the patient has high myopia, we can suggest for the patient that they will undergo phakic intraocular lens implantation, which will even have better quality of vision, as they will as the magnification of the intraocular lens will be much less than the contact lens and the glasses. So this is what is called about the anisometropia. What is let's now talk about the anisocoria, which is basically the problem resulting from the anisometropia. The anisocoria meaning that there will be difference in size, difference in the image size in the retina. So there will be the one retina will receive large image and the other will receive a small image, and this will be resulting from the anisometropia. So the brain will not be able to fuse both images coming from both eyes, resulting in confusion and eye strain and headache. So anisocoria is unequal retinal image size and shape in both eyes. So not only the size, but also the shape will make a difference and all will make a confusion at the brain level. However, note that the small degree of anisocoria is important for stereoscopic vision. This will be discussed in much more details when we will go through the binocular vision lecture in the physiology. We will say that in order to see an object with as a 3D structure, so you can see a third dimension of an object, this needs that you see that the object from different angles. And when you see the object by your both eyes from different angles, this will lead to you see that the objects are, or the each picture at each eye will be slightly dissimilar. This is very important. The object or the object image at your eye will be slightly dissimilar from the other eye. If they are completely dissimilar, this will lead to confusion. If they are exactly similar, this will lead to loss of stereoscopic vision, as each eye will be like a repetition from the other eye. So you will not see the third dimension and you will not see stereoscopic vision. So it is just by the small degree of anisocoria that will make us appreciate the stereoscopic vision. Okay, so let's know what are the causes of anisocoria. It can be either anatomically or optically. These are the reasons that why the anisocoria occurs. So for the anatomical reasons that will result in anisocoria, this is due to difference in the distribution of rods and the cones. So wider distribution will lead to smaller image. I will give you an example of a common disease in the retina. This is called CSR, or central serous chorioretinopathy. This disease occurs more common in males, more common of type A personality, and more common in young age. This will lead to accumulation of fluid below the neurosensory retina. So it will lead to neurosensory retinal detachment. And this disease characterized by the patient will report that they are seeing smaller image. And why does this occur? This is because when the retina is separated by presence of fluid, like here, this will lead to this fluid will intervene between the photoreceptors. So the photoreceptors will be distributed over large area. So when the image will be perceived by this photoreceptor, it will be perceived by smaller number of the photoreceptor or fewer number of the photoreceptors, as they are widely separated. And this fewer number of photoreceptors will lead to smaller image. So the anisocoria can be due to an anatomical reason, not only an optical reason. The second thing is optically. So the optically, caused by the anisometropy, as we just mentioned. So the variability in the power and the position of the correcting lens, as they are not placed in the anterior focal point, as we just mentioned. The refractive condition of the eye will also have an impact on the anisocoria and the distance of the nodal point from the retina. The types of anisocoria could be symmetrical or asymmetrical. So for symmetrical, meaning that the image is distorted in all directions in one meridian. So if this is an image, like an image for a window, and the patient of anisocoria looks at it, it can be symmetrically distorted over the horizontal meridian. So it will be like more horizontal like vertical, or it can be more vertical like horizontal. So this will be called a symmetrical anisocoria. Or it could be asymmetrical, so the image will be distorted irregularly in different media like this. So there will be an irregular enlargement or irregularly small image in different media. So here is what's called the anisocoria, the symmetrical and asymmetrical. What will be the complaints of patients with anisocoria? The patient will report that they have headache, so the headache will increase during or visually demanding tasks like reading, or if they are in the cinema, they also can complain from weakness or pain of the eyes, which are collectively called ocular athenopia. So ocular athenopia meaning that there is a strain in the eyes. The strain in the eyes will result in pain and lacrimation and the congestion and discomfort of the eyes, and visual symptoms in the form of blurring of vision and tendency for diplopia and squint. So how can we treat? It will be the same like treatment of anisometropia more than 4 diopters. So we can correct it by glasses with the certain precautions as we mentioned, can correct it by contact lens, or we can correct it by surgery. So this is what is called the anisocoria. And this anisocoria will be resulting mainly, or in practice, the most common cause of anisocoria will be the anisometropia. Now we'll talk about what is called presbyopia. What is meant by presbyopia? It is not uncommon to find older population, like above 40, having a usual complaint of having a problem with near vision. So they are no longer be able to read a book, they are no longer be able to look at the mobile phone, and they tend to push the book or the mobile away from their eyes in order to see clearly. So why do this occur? This is a physiological process called presbyopia. The presbyopia meaning that it is the recession of punctum proximum beyond the comfortable distance for the near work. So what is the punctum proximum and what is the comfortable distance for the near work? The punctum proximum is the nearest point at which an object can be seen clearly when the accommodation is maximum. So let's just remember that when we were born with a large amount of accommodation. So it will be about like 20 diopters, so that the child who has, or the neonate or the newborn who has high hypermetropia will be able to compensate for this high hypermetropia by his accommodation. The more we get older, the more the eye gets longer and the less accommodation that we have. So as we get older, the accommodation will decrease. And usually we all read, or most of us will read at about 25 centimeters. So in order to see clearly or to read clearly at 25 centimeters, this means that we need about 4 diopters, because we know that the power will equal 1 divided by f. So the focal length of the lens will be by meter will be the power of the lens will be will equal 1 divided by or 1 over the focal length of this lens. So if we have 4 diopters of accommodation, we can see clearly any image or any object at 25 centimeters. And 4 diopters of accommodation will be at we reach 4 diopters of accommodation at the age of 40. So this is the lens will gradually decrease, or the power of the accommodation will gradually decrease from the moment of birth till we reach the age of 40. So at the age of 40, it will only reach 4 diopters. And since then, from then and later, the patient will complain from near vision or near vision problem, because they are no longer be able to see clearly the objects placed at 25 centimeters. So what is again the this we just mentioned this to explain what is meant by the punctum proximum. So if the punctum proximum, as we are young, they are far from the eye. So it could be about 2 meters, 1 meter, 70 centimeters, 60 centimeters, 25 centimeters, while we are 40-year-old, because we exert all our accommodation, which is the 4 diopters, in order to see clearly. If any object beyond this punctum proximum, so it will be about 10 centimeters, it will not be seen clearly, because for an object placed at 10 centimeters to be seen clearly, this needs a 10 diopters accommodation. And at this age, we don't have a 10 diopter accommodation. So if we have, again, the punctum proximum is the point at which an object can be placed and it can be seen clearly while we exert our accommodation at the maximum. So you can consider it like a car, and you push the gas pedal to the maximum so that you have the maximum speed of the car. Punctum remotum is the term that we mentioned earlier, and this will be the reverse of punctum proximum. So it will be the farthest point at an object which can be seen clearly, and which image really falls on the retina as the accommodation is fully relaxed. So the punctum remotum, when the accommodation is completely relaxed, their image, if an object placed at the punctum remotum, then their image will fall on the retina. And this is in the condition in which the accommodation is fully relaxed. So this will be the condition of punctum remotum. And as we said before, in case of emmetropia, in the emmetropia, we can look at the infinity and we can see clearly, because the object from the infinity will fall on the retina, so that the punctum remotum in case of emmetropia will be infinity. However, in case of myopia, the punctum remotum will be a point in front of the eye, while in hypermetropia, it will be a point behind the eye, or a virtual point behind the eye. So for this example, you can see clearly that the person sitting looking for this match can see the television clearly, but he is unable to perceive the remote control and his hands clearly, because he has presbyopia, and that's why he has a problem with the near target. So this is like a hypermetropic shift that occurs after the 40 years old. So when does the presbyopia occur? As we mentioned, at most individuals, it appears at around the age of 40. But as we said, it is a hypermetropic shift. So if the person is already hyperope, this person will suffer from a near vision problem earlier, so that their presbyopia will occur earlier, and they will complain much more earlier than normal individuals, because the presbyopia occurs over an existing problem of near vision. While the myopes or the reverse occur, in the myopes they tend to have a problem with far vision, so they see the near targets clearly because their eyes are powerful and they have powerful refractive system. So if they aged 40, they will not appreciate the presbyopia because they will having slight weakness of the eye, or the natural and the physiological weakness that occur in the eye will be compensated by the powerful refractive system. So they will be able to see the near targets clearly, and if they are gets more and more older, then if the presbyopia amount exceeds the myopia amount, then they will start to complain. And this is known as the second sight. I guess that you all know this from the undergraduate study. So the second sight, meaning that the myope will use his glasses before 40, but he tended to discard his glasses after the age of 40 because they can see clearly the near targets, and the physiological phenomenon of the presbyopia was compensated by the myopic refractive error. Here we come to another issue. So if, for example, if we have a 40-year-old and we look at an object at 25 centimeters, so we have four diopters of accommodation. If we use these 4 diopters of accommodation all the time, does this will make us comfortable? The answer is no, because a ciliary muscle that is responsible for accommodation is like any muscle in the body. If you don't contract your muscles or your body muscles all the time, but they need to be contracted and relaxed. So if you contract the muscles, all the whole amount of muscle all the time, this will lead to weakness and pain and athenopia. So in order for the muscle or the ciliary muscle to be comfortable, you need to have a reserve for this accommodation. And this reserve is about 30% of the total amount of accommodation. Let's say, for example, the comfortable distance for near work is about 33 centimeters. So you need about 3 diopters of accommodation. So 100 divided by 33, it will be 3 diopters. So if I have only 3 diopters, then I will be comfortable at reading at 33 centimeters? The answer is no, because I need about 30% or third of this accommodation to be at rest. So I need only to use 2 diopters instead of the 3 in order to read with comfort. So a patient will start to complain when his accommodation will become less than 4 diopters, because he will use 3 diopters of accommodation and 1 diopter as a reserve, and as he gets older and as he gets as he will have start to have less diopters of accommodation, he will need, or he will be forced to use his reserve accommodation, and this is when the patient starts to complain. So let's say, for example, this is an emmetropic patient. So for the emmetropic patient, as he gets at the age of 40-year-old, he will no longer be able to see the near target over the fovea or over the macula, but the near target, they tend to be focused behind the retina. So what he needs to do is to do accommodation, so he increases the power of the lens in order to put the light rays over the retina. So this, if it occurs at the emmetropia at age of 40, it will occur less later on in the myopia, because the eye is already large. That's why when the patient is at 40-year-old, the image will fall on the retina, not behind the retina, but because the eye enlarged in size. So this will lead to that the presbyopia manifestations will occur later on in myopia. The reverse will occur in hypermetropia, so they have smaller eyes, so they are already having a problem with near vision, and this problem has been augmented and exaggerated by the presbyopia. So they tend to complain earlier, maybe at 37 and 38 or 36 years old, and they will suffer from the presbyopia earlier. Okay, so why does the presbyopia occur? It can be due to physiological reasons, which is more common, or pathological reasons. For the physiological reason, it occurs due to as a natural process of aging. This will result in ciliary muscle weakening, which is the responsible for accommodation. Also, this will lead to slackening of the zonule. You need to remember this concept of slackening of the zonule, which means that there will be no space for the zonule to work on the lens due to increase the lens size as it lay down fibers by the age. Also, there will be decreased lens deformability due to sclerosis of the lens fibers. So as we get older, the lens fibers become less flexible. So they tend not to be, the lens cannot reshape itself as in the young age group, so that they will not be more spherical and they will not increase their dioptric power. So here is an example. If we look at this book and the lens is an unaccommodated state, since the book is near the eye, its image will fall behind the eye. So the image will be blurred over the retina. So what we do is contraction of the ciliary muscle, and this contraction will lead to relaxation of the zonular fibers, leading to the stretch of the zonular fiber over the lens capsule will be eliminated, leading to anteroposterior bulge of the lens. And this bulge of the lens will leading to that the lens will assume a globular shape and will increase its dioptric power, leading to more refraction of the light rays over the retina, and will focus the light rays over the retina. So what happens as we get older, that the ciliary muscle gets weak, and the lens fibers or the lens increase in size as we get older. There will be continuous lay down of fibers of the lens, so there will be little space between the zonular muscle and the lens, so there will be no space for the zonular fibers to react on the lens, and this is what's called slackening of the zonule. The third reason that the lens become more sclerotic and their fibers become more hard, so it will be difficult for the lens to assume this globular shape. These are the physiological reasons which occur almost at all persons and all individuals, as it is a normal aging process. But there are other reasons that may cause the presbyopia to appear earlier or to appear in certain conditions. For example, if the person have a poor general condition or poor general health, this may affect the zonule as well, or affect the ciliary muscle as well. The prodrome of the glaucoma can cause presbyopia. So for patients who will have an attack of glaucoma, this will be high rise of the intraocular pressure, which will lead to ischemia of the anterior segment, like ischemia of the ciliary muscle. So the ciliary muscle will be non-functioning, and this will lead to affection of the ciliary muscle, causing a transient presbyopia or a transient loss of accommodation. Also, atropine will cause, it is a parasympathetic, so it will cause a stimulation of the parasympathetic system and leading to relaxation of the zonular fiber, leading to relaxation of the ciliary muscle, so it will cause loss of accommodation. The persons who have presbyopia, what will be their complaints? So they will come into the clinic complaining from headache. So especially this headache will occur from near work, like working on the computer or working on them or reading. Also eye strain, and there will be like a throbbing pain in the eyes. There will be redness and the congestion of the eyes and neck and the back pain. So how can we treat and how can we correct this condition? This can be either any of the three routes. It can be either with a contact lens or glasses or surgery. So for how can we correct with the presbyopia? This has a certain rule of correction in order to maintain the accommodation reserve for the patient so that this patient will have a comfortable near vision. The first of all, if the patient asks for near vision correction, you need to first correct the far vision. So it is non-negotiable. It is mandatory that this patient, if any patient complaining from the near vision, to start first with far vision correction, as you will build up on this far correction to make your near correction. So first, for example, let's say that the patient has a +2 diopters. So correct first the refractive error for far until the patient reach about 6.6 or the best corrected visual acuity for far. Then after correction for far, then you correct for near. The first step in correction for near is to determine the patient near point. The patient near point or the punctum proximum, as we said, it is the nearest point toward the eye at which the patient can see it clearly with the accommodation is fully contracted. So we need to know how much does this patient have accommodation? How much the accommodation does this patient have? This can be determined by approximating a target in front of the patient's eye and ask the patient to report when the target appears blurred and he can no longer be able to see this target. So let's say, for example, if the punctum proximum for a patient is about 40 centimeters. So beyond the 40 centimeters, the patient cannot see clearly. So we need to determine what is the amplitude of accommodation. So we will divide 1 over f. So this patient will have 100 over 40. So this patient will have 2.5 diopter of accommodation. These 2.5 diopters of accommodation will enable this patient to look at the near target at about 40 centimeters. So these 2.5 diopters are there. After knowing what does the patient have, let's know what does the patient need. First, we need to reserve a third of the accommodation and allow 2/3 of the accommodation only to be used. So the patient shouldn't use his all 2.5 diopters, otherwise the patient will complain of headache and eye strain. So we will need to multiply this 2.5 with 2/3 so that it will equal 1.75 diopters. So the patient is allowed only to use his maximum of 1.75 diopters of accommodation and to leave 0.75 diopters of accommodation at rest or as a reserve in order to be at comfort. So the patient can use only 1.75. So let's know what are the patient needs. The accommodation, the patient read at 33 centimeters. So this is the comfortable distance for this patient. So in order to read at ease at 33 centimeters, we need 3 diopters of accommodation. This can be done by dividing 100 over 33. So this patient needs 3 diopters in order to see clearly at 33 centimeters. But the patient have only 1.75 and of amount of diopteric value or of accommodation, so that we need to continue or to add on this the patient and accommodation as a glasses in order to complete for the 3. So what does or how much reading aid does the patient need? It will be to subtract 5 minus 4. So 5, which is the total amount of accommodation that the patient need, will be 3 diopters, and the total amount of minus total amount of accommodation that does the patient have after removing the reserve. So 3 minus 1.75, then it will be equal 1.25 diopters. So this patient needs a glasses plus glasses of 1.25 diopters in order to see at 33 centimeters clearly without any strain to compensate for his presbyopia. So to have a more clear concept about this issue, let's see this example. So if we have a presbyope who wanted to work at about 25 centimeters as a distance, and his near point is only at 50 centimeters. So his punctum proximum is at 50 centimeters, but he wanted to work at 25 centimeters. So what is the amount of the near add? So if the patient can work clearly and they see clearly at 50 centimeters, then this means that the patient has an accommodation of only 2 diopters. This can be resulting from the rule, the amount of the accommodation will be equal 1 divided by the punctum proximum. So if this patient who has only 2 diopters of accommodation, can he see clearly at 25 centimeters distance? The answer is no, because if he wanted to work at 25 centimeters, he needs 4 diopters of accommodation, and he has only 2. So what can we do? We should leave the third of accommodation at rest for comfortable vision. So for the third of the 2 will be 1.3, and then the amount of the near add will be 4 minus 1.3, so it will be equal to 2.7. So 2/3 of the accommodation should be at reserve, which will be 1.3 diopters. So we need to just add on this 1.3 diopters in order to reach the 4. So this will be 2.7 diopters. This will be the reading glasses that the patient will need in order to read comfortably at 25 centimeters. Another method for the correction of the presbyopia that we mentioned before is the lens decentration in all the presbyope. Or we said before when we were talking about the prisms, about lens decentration, that if we have an old presbyope, this old presbyope doesn't have accommodation, and in order to supply his accommodation, we give him plus lens. But the problem is, in order for reading, that we don't need only the accommodation, but we also need the convergence. So the convergence is stimulated by the accommodation or the near reflex. If the near reflex is halted or it doesn't work, then the convergence will not work, and this will lead to, despite that the patient has a full correction of his reading glasses and he has the accommodation already supplemented, but he still cannot read comfortably because he lacks accommodation. So we need to provide both solutions for accommodation and for convergence. So what can we do for the convergence? We do the lens decentration. So the decentration is by pushing the center of the lens nasally in both eyes. This will lead to what's called base and prism. And this lens will so that the plus lens will relieve accommodation, and the decentration will relieve the convergence. So how much decentration we can use? It will be the prism deviation in diopters, or the prism deviation in the diopter that we needed to do the decentration will equal the power of the lens multiplied by the decentration of the optical center in centimeters. As we know, this is called the Prentice rule. So for example, if we have a normal individual or a presbyope that has plus lens in front of his both eyes, and he is able to converge, so both he will not have any problem with reading or will not have any problem with near target, because the object will enter through the center of the lens to the fovea, and both eyes will be able to converge, so they will be able to see the near target. However, the problem occurs when we have an older presbyope that he has, that in which we place the plus lens, and this plus lens correct only the accommodation but doesn't correct the convergence. So these persons will have weak convergence. So in such condition, what we will do is to just decenter the lens. So we will shift the eye or shift the light rays, instead of entering through the center, it will enter through the periphery of the lens, which will lead to prismatic effect, causing a deviation of the light rays toward the base, and the image will be at the apex. So the image will be at the apex of each eye, and since the eye so the image will be located outward or outside, and since the eye is already are outward, or they are present outside, away, more temporal, away from the visual axis, so that these eyes will be able to see the image clearly, as they are not able to converge. Dr. Shadi asked about in the myopia is the reverse. We don't put minus lens for the myopia. So if we have a myope who is -3, for example, or -1, and he is not still cannot read the clearly, or cannot see clearly, so that we will increase his add or reading add. So we will put +2 or +3 on his minus glasses, so it will be leading to more, the net result will be about +1 or +2. So it will be no problem, as the lenses will be in front of his eyes will be plus, so that it will be again base in. But what happens if the patient is myopia, for example, -6 or -5? This patient will not have a problem with reading in the first place. This patient will not need a reading glasses in the first condition. But if the patient has a convergence problem, or that the patient has a convergence insufficiency, so we need to do the Prentice rule and we need to do decentration, then the patient will have a minus lens in front of his eyes. In such a condition, we do the minus lens, in which that the base will be out. So the minus lens will be like this, and the base will be out, so that as we will do a temporal, or the decentration will be toward the outside, so that the image will be falling on the toward the apex, and then the image will be toward the base. So sorry, the light rays will be deviated toward the base, and the image will be deviated toward the apex, so that the image will be displaced temporally, so that these eyes who have convergence insufficiency will be able to see the image clearly without need to converge. So if we need to use a minus lens for people who have myopia with convergence insufficiency, in such condition we need to do the reverse, or we put the minus lens with temporal or outside decentration. The contact lenses can be also used for presbyopia. So although they are not commonly used for presbyopia, but it is still an option. So for example, the patient can use their contact lens for reading, or they can use the contact lens for far vision, and they use in conjunction with glasses for near vision. So this will be the case. Other options that emerged for treatment of presbyopia will be other laser correction, like monovision LASIK, and monovision with conductive keratoplasty, which is no longer used, intracore or refractive lens exchange, or corneal inlays or outlays. So this is just beyond the basic and optics exam, but just for your information, for what's called monovision LASIK, in which we correct one eye for near and one eye for far. So we make one eye more toward the emmetropia or hypermetropia, and this eye will be able to see the far target clearly, while one eye is corrected for near vision. So we make one eye is more myopic, so it can see the near target clearly. This can result in confusion at some patients, but in order to avoid this confusion, we ask the patient to use a contact lens that is that's corrected for near for one eye and the other for far for the other eye for 1 week, and to see that if the patient will be able to tolerate this monovision or not. If the patient is able to tolerate this monovision, then we can go for laser vision correction. The other method is used like it was a historical used method for correction of the presbyopia. It's called the conductive keratoplasty, in which we use a radio frequency probe that cause thermal photocoagulation at the periphery of the cornea, and this will lead to reshaping of the cornea, causing increasing its refractive power and increasing its refractive power by 1 or 2 or 3 diopters that will lead to compensate for the presbyopia. Another method is the use of the laser vision correction in order to reshape the cornea. The central part of the cornea or the central 3 millimeters of the cornea to make it like this in this concentric rings in order to increase its power and allow it to see the near targets clearly. This is called intracore or supracore, or it has other trade names. Another method is the refractive lens exchange, and this is usually occurs if the patient is emmetrope of one eye, and the other eye can be the lens could be removed, and we can make this lens myope about -1 or -2 or -3. So this eye will be more powerful, and this eye will be able to see the near targets clearly. So it is like the same concept of the monovision. So one eye, which will be the unoperated eye, will be seeing the far target, and the operated eye, which has undergone the refractive lens exchange, will be seeing the near targets. Other artificial tissues or membranes have been invented in order to place inside the cornea, which are called corneal inlays, or sometimes called the cornea onlays. They are about tissue that is inserted into the cornea that will make the eye more able to see the near target. So it will increase the refractive power of the central part of the cornea, and making it more able to see the near targets. So it will be implanted inside the cornea.